Hello and welcome to Icon Group's final Facebook Live event for 2024. Ian Irving is my name and I'm Icon's Chief Medical Officer. I'm also a practicing haematologist at Icon Wesley and the Wesley Hospital. Tonight, however, we're not talking about haematology, but we're going to be delving into the topic of lung cancer. Lung cancer is one of Australia's commonest cancers, affecting a large number of patients each year. And it's certainly a cancer that we're actually seeing more and more of throughout our Icon Cancer Centres across Australia. We've got tonight with us two of Australia's foremost experts in lung cancer. We have radiation oncologist, Dr. Megan Berry. And introducing Megan, she's a radiation oncologist who works publicly at Liverpool Hospital and also privately at Icon Cancer Centre, Revesby. Megan has particular expertise and interest in lung cancer, breast cancer, and also stereotactic radiotherapy to treat spinal tumours. So, Megan, I very much welcome you and thank you for giving up your evening to talk about lung cancer to our audience tonight.
Thanks for having me, Ian.
And complementing Megan, we have Dr. Daneek Patel, who's a very experienced medical oncologist in South Australia. Daneek works publicly at Lyell McEwen Hospital in Adelaide and also works at Tennyson and Windsor Gardens Icon Cancer Centres. Daneek has a special interest in lung cancer as well as treating colorectal cancer and prostate cancer. So Daneek, thank you again for turning up tonight and educating us on the medical oncology aspects of lung cancer.
Thanks for having me here. Very excited.
Tonight's show will follow the format of previous Icon Facebook Live events. So we'll first hear from our experts, and for the first half of the presentation, there'll be didactic discussion from Megan and Daneek. Then in the second half of the show, we'll have time for questions. So please, through the Facebook Live platform, submit your questions for either Daneek or Megan, and we'll try our best to get to as many questions as possible. As always, tonight's event is being recorded, and the recording will go up on the Icon Cancer Centre Facebook page. It will be added to the library of now quite a few Facebook Live events that we've done covering most of the major cancer subtypes. And please feel free to watch the event at your leisure. As mentioned at the start of the broadcast, tonight's show will be our last event for 2024. We'll certainly be returning in 2025, and the first Facebook Live event for next year will be on World Cancer Day on that first Tuesday in February 2025. So that's enough of hearing from me. I think it's time we heard from our experts, and I'm going to turn to Daneek first, Dr. Daneek Patel. If you could please walk us through, Daneek, the various different types of lung cancer.
Yeah, it's quite fascinating how the lung cancer has been classified. So the initial classification is based on how the cancer cells appear under the microscope. So the cell which appears small, it's called as a small cell lung cancer, which is very strongly associated with smoking. And the cell which is non-small cell, means it doesn't appear small, they consider it as a non-small cell cancer. These are the two broad classifications. And then non-small cell cancer is further classified in adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. Means that's something what normally we label to the patient, like you got this carcinoma. But very interestingly, in last 10 years, it's the boundary of this didactic classification of the cancer based on the microscopic appearance is disappearing. And what we are increasingly seeing is that we type cancer based on their genomic profiling. So if cancer is driven by the one particular mutation, just to give you an example, EGFR, then you'd say that it's an EGFR driven cancer. So you can further divide cancer as a targetable lung cancer versus non-targetable, which is the majority of the population.
Right. No, thank you. And it's interesting to hear, as you say, that microscopy as a tool for classifying cancers, which has been the mainstay of what we've used to classify cancers for decades and decades, and certainly we use a lot of microscopy in hematology. It's interesting to hear what you're saying, that microscopic classification system is being replaced by a genetic classification system. Do you think it will ever be a complete changeover to a molecular classification system away from microscopy?
Pathologists are not going anywhere. we still need them. So I think it's a more complementary, the genetic profiling, but certainly now I don't diagnose patient lung cancer without having that genomic profiling. So that's how important it is in a small proportion of patients where genetic profile is not that useful yet. But I think time will come where every patient will have a genomic profiling, and it will come along with the pathological classification.
Right. No, that's thank you for explaining that to us. And that makes sense, that we'll still have the microscopic classification system to give us the subtype of lung cancer. But on top of that, complementary to the microscopic classification, we'll have the genomic profiling. Is genomic profiling done on every new diagnosis of lung cancer? And if so, Daneek, is it rebatable for patients under the MBS?
The good news is that Australian government has approved comprehensive genomic profiling just this year. So we used to have an abbreviated version of genomic profiling up until now, but now patient can have a comprehensive genetic profiling. So I would suggest my patient to make sure that they ask their cancer provider to ask whether they have a comprehensive genomic profiling, because the older version of next generation sequencing used to miss out on some of the rare genetic mutation. But now we can fund through the Medicare comprehensive genomic profiling.
Oh, great. No, that's great to get that update. And it's also great news for patients and their relatives and loved ones that such testing is available through the MBS. So thank you. Final couple of questions for you, Daneek, before I'll throw over to Megan. Can you tell our audience, what are the causes of lung cancer? Who gets lung cancer?
Yeah, I think still elephant in the room is smoking. So smoking is still very predominant cancer causing. But I think over last 10 years, overall the smoking rate has declining. So the cancer associated with smoking is also declining. But what's rising lately is non-smoking related lung cancer. And what we know that this particular group of patients have a genetic abnormality as well in their genomic profiling. So what we still don't know exactly in individual patient, but the majority of the reason it's how our body interact with the environment. So lots of occupational hazard. So silica, dust, then metal grinding, then coal, then also like a lot of mining in Australia, hydrocarbon. Those are also the risk factor for the lung cancer. For a woman, the domestic vapor. So when you cook, there is a risk of vapor inhalation as well. And that's predominant cause of the lung cancer in China and India. And also what's new, which we don't really know, is about vaping. So the vaping is rising. It has some chemicals which has a carcinogen potential, but it's cause cancer or not, the association has not established.
Right. I guess though, even though the association of vaping with lung cancer may not have been proven as yet, it would still be something we'd encourage everyone to not vape and to not take up vaping. And it's much better, as well as not smoking, certainly not vaping, and as a precautionary principle not to start such habits. And as you point out at the start of your answer there, smoking rates have declined significantly in Australia over the last number of decades, thanks to a lot of factors, including excellent government policy. And it's a fantastic thing because we all know that for a whole host of cancers, prevention is better than treatment. And so not smoking is of paramount importance. Megan, let's go over to you now if we can, and if you could explain to our audience watching the stages of lung cancer and how we actually stage lung cancer.
Thanks, Ian. Well, yeah, I guess staging's the way we divide up lung cancers into different groups, and it's based on how large the primary cancer in the lung is, whether or not it's spread into any lymph nodes in the chest, and whether it's spread to any other spots elsewhere in the body. And staging guides us doctors as to what the most appropriate treatment is for a particular patient based on the stage. And it also guides us about the likely prognosis of the cancer depending on the stage. So when we see a patient in the clinic with lung cancer, there are a number of scans and tests and things that we do to work out where the cancer is located in the body and where it's spread to and how big it is. So some of the sort of standard staging tests that we do would include CT scans, PET scans and MRI scans. We also sometimes send our patients for a procedure called an EBUS, which is an endobronchial ultrasound, where a camera is passed down into the airways and samples or biopsies are taken from lymph nodes to see if there's cancer cells in them. And sometimes we'll also even drain fluid from the lung to see if there's cancer cells in that too. And then I guess the system we use for staging is something called the TNM staging system, which is used across a lot of types of cancer. And the T refers to tumour, and that's a grouping according to how big the primary tumour is. And then we've got the N, which is the nodes, and we've got N0, N1, N2, N3, and it all depends on whether they're spread to lymph nodes in the chest or the lower neck and where the lymph nodes are. And then we've got the M, which stands for metastases, and that's whether or not the cancer's spread to other areas of the body, like bones or liver or brain or adrenal glands, etc. So when we combine the T, the N, and the M, we get an overall stage. And there's 4 main stages for lung cancer. You've got stage 1, which is where there's a small cancer in the lung and it hasn't spread anywhere else. You've got stage 2, where the cancer's only spread to nearby lymph nodes or first echelon lymph nodes. Then you get to stage 3, where there's a larger cancer, or it's spread to lymph nodes in the centre of the chest or the mediastinum. And then when we get to stage 4, that's when the lung cancer is spread outside the chest to involve other organs. And it's also called stage 4 if the cancer is spread to the pleura or the lining around the lungs. And Danik mentioned before that we have small cell cancer and non-small cell cancer. For small cell cancer, we still use TNM staging as well, but the main system we use is a little bit more basic. So people may have heard of limited stage small cell lung cancer, where the cancer is just in the chest and can be treated with radiation. And then there's extensive stage small cell lung cancer, where it's spread elsewhere or it can't be treated with radiotherapy.
No, thank you for that, because it's clearly a very complex area, but I think, yeah, you've explained that very well, Megan. And so just to recap, in small cell lung cancer, often it's divided into limited stage or extensive stage. And then for non-small cell lung cancer, which includes the adenocarcinoma and squamous cell carcinoma, we use the TNM system to derive a stage of 1, 2, 3, or 4 for the lung cancer, if I'm hearing you correctly. Great. Well, I think if you've got that information through to myself as a haematologist, I think it'll be very clear for those listening. Thank you and watching. Just you mentioned we use a PET scan for lung cancer. Does everyone who's diagnosed with lung cancer have a PET scan? And what does PET stand for in the PET scanning?
Yeah. So yeah, PET scans become a standard of care for staging in lung cancer, and it's a positron emission tomography scan. For lung cancer, we use a radioactive tracer called FDG, and that's injected into the patient, and that's taken up by cancer cells, so cells that are very active and turning over quite a bit. And what we found is that PET scans can identify where the cancer is more accurately than just a CT scan. So often there can be spots of cancer that the CT isn't clear about, or the CT hasn't picked up, but a PET scan will light up beautifully and we'll be able to more accurately stage the cancer.
Right. No, great. Thank you. Let's go over to treatment now. So we've gone through diagnosis and causes of lung cancer and staging. Talking first with you, Megan, and then I will go over to Danique. But for early stage lung cancer, and I'm thinking stage 1 or 2, could you give us a flavour for what sort of treatment modalities are available to treat early stage lung cancer, please, Megan?
Sure. So yeah, as you said, early stage lung cancer is usually referring to the stage 1s or the stage 2s, where they're sort of smaller cancers that are confined to the lung or maybe only spread to very nearby lymph nodes. And at that point, we're definitely going for cure. And the standard of care for curative treatment for early stage lung cancer is surgery. So surgery is the gold standard. And the idea of surgery is literally to remove the tumour and give a bit of a margin around it and clear it out. There's different types of surgery that can be used for early stage lung cancer. The most common type is a lobectomy. So you literally remove the affected lobe of the lung with the cancer in it, and usually a few lymph nodes as well. But you can also do smaller resections or sublobar resections where you just take out a segment of the lung, and that can be useful for really small cancers or patients who won't be able to cope with the whole lobe being removed. You can also have a pneumonectomy, which is a really big operation where you remove the whole right lung or the whole left lung, and that's for bigger cancers or cancers that are quite central or spread over a couple of lobes of a lung. And surgery these days for lung cancer is really fantastic, and it's generally done with a VATS procedure or a videoscopically assisted thoracic surgery approach. So it's minimally invasive, and the surgeon just puts little cuts, little ports into the chest, and then inserts cameras and surgical tools in that way to remove the cancer. And some hospitals even have robotic cardiothoracic surgery, which is even, again, less invasive and produces great results for patients. But then if a patient's not suitable for surgery for whatever reason, it might be due to their age or their other medical problems or their own preference to not have surgery, a very effective and very useful alternative is radiation treatment, which is what I do. There's two main types of radiation treatment that we use for early stage lung cancer. So if we've got a very small lung cancer on the periphery of a lung, preferably, we can target that with something called stereotactic ablative body radiotherapy, which we shorten to SABR. And that's a really high dose, high precision type of radiotherapy that we aim at a very small target. And we can often treat these cancers in a very few number of attendances for treatment. So we can even treat a small lung cancer with just one big dose of stereotactic radiotherapy, or maybe 3 doses or 4 doses of radiotherapy. And it's very well tolerated. It's very convenient, and the outcomes are really good. So they are comparable to surgery. So we've probably got, you know, a greater than 80% chance of getting rid of a small cancer with stereotactic radiotherapy. And then the alternative, if the tumour is not suitable technically for stereotactic treatment, is to use conventional radiotherapy. So people would have heard of patients having courses of radiation over a number of days, like a treatment each day for a number of weeks. So that's conventional radiotherapy, and that works very well as well. So for a lung cancer, we could treat with daily treatments over 3 weeks or 4 weeks with radiotherapy and have good outcomes. I'll mention briefly as well that if patients aren't suitable for surgery or radiation,
Yes.
there are occasions where we've referred to our interventional radiology colleagues for something called cryoablation, where they put a needle in with a cryoprobe that puts this gas that freezes the cancer. That's sort of our last resort treatment when you haven't got any other options. And I guess in this space as well, I should probably make a nod to Danik as well, and just say that after a patient's had surgery and we've had a look at their results, there are some indications to give further treatment like chemotherapy, and even an exciting area at the moment is the use of what we call neoadjuvant treatment before surgery, so giving a combination of chemo and immunotherapy before surgery to get some excellent outcomes.
Right. No, thank you, Megan. Very comprehensive. And that's a great segue to go over to Danik. And it's great that patients have so many options. And as you point out, Megan, in early stage lung cancer, the goal is cure often, which is fantastic. Danik, unfortunately, we know with cancer, it is a disease that can recur after initial curative intent treatment. It's a disease that sometimes when it's diagnosed, it has already spread. And so often in these situations, we're not always talking about cure, but rather we're talking about control of the cancer. Could you outline for our audience what are the various treatments that are given for more advanced lung cancer?
Yeah, I mean, it's unfortunate that lung cancer, like almost 50 to 60% of the time, diagnosed in a late stage. So we are in that situation most of the time. So as I alluded earlier, that we divide patients for a non-small cell lung cancer between targetable lung cancer, where there is some genetic mutation. So that's something what I check for most of my patient when there is no crisis, clinical crisis, where I have to treat without waiting. But majority of the time, we try to look for a genetic mutation. And then the 80% of the patients where they do not have a genetic mutation. I think for them, so the most important treatment aspect is going to be the immunotherapy. So we have been giving chemotherapy for many years, but many of our patients, they are elderly patients, they cannot handle chemotherapy very well. So the immunotherapy has remained the backbone for any treatment in advanced lung cancer. Some patients go immunotherapy by itself if their tumor is having some biomarker which suggests that they will respond very well just to immunotherapy alone. Some patients where we combine immunotherapy with chemotherapy, which works synergistically, and that's the mainstay of the treatment for majority of our patients, including small cell cancer, where we give a chemotherapy with immunotherapy. Now, the patients who have a targeted mutation, I think that's something what's new, exciting area where we treat patients with the tablets, and these tablets are designed to target that mutation. Sometimes we use the word driver mutation because we believe that mutation which carries the message to proliferate and spread. So if we can stop that particular genetic mutation by either tablets or infusion, then we can halt the cancer spread. And that's where we treat different treatment with the mutation.
Right. And you mentioned 20% of cancers only have a targetable mutation found on the genetic screening. Is that right? And if so, with the better genetic tests, is that number rising, and will it rise in the future, do you believe?
I think it's very interesting actually, because many of our patients now having this new generation of genetic testing, and we found more genetic mutation. And because now the umbrella of genomic profiling is expanding. So just to give you example, one of the mutation called NTRK, ANTRAK. Now this genetic mutation we learned from the pediatric cancer patients, and but it also positive in a 1% of the lung cancer as well, which we never used to check it out. But now with this comprehensive genomic profiling, we also check this rare mutation. And if they have this mutation, they can go on a tablet, which is Medicare reimbursed.
Right. Excellent. No, it's a brave new world, and will only keep changing. You mentioned immunotherapy, and it's been in the last 10 to 20 years, there's been an explosion in the use of immunotherapy, and lung cancer is one of the cancers, I guess, that commonly is treated with immunotherapy, as you've told us, Danique. Could you explain to our audience, how does immunotherapy work? How does the actual cancer die with immunotherapy being given?
Yeah, so the way we can flip the cancer, why flip the question that why we don't have a cancer. So the many patients have a smoking history, but they don't get cancer. So their immune system, which prevent cancer cell to grow. So that's something what's immune system has a surveillance function. So what we try to do by giving the immunotherapy to reignite and re-educate our immune system to fight against the cancer. So there are different pathway in our immune system which we can harness by giving this immunotherapy. So just like a vaccine, like when we give a small dose of vaccine, our body get immune to that virus. Similarly, this cancer is hiding from our immune system, and when we give this immunotherapy, we unleash this lock and hiding mechanism, and then immunotherapy help our immune system to fight against the cancers, and that's very fascinating concept.
Yes, absolutely. I remember when it first came on the scene, and it was such a different way of treating cancer compared with chemotherapy. You're right, it's a completely different concept. What are the potential side effects of immunotherapy? I think many of our viewers will have a fairly clear understanding of potential side effects of chemotherapy, with hair loss and nausea, potentially vomiting, weight loss, diarrhea. But what about with immunotherapy? What are the particular side effects that can occur with immunotherapy?
So the immunotherapy is antibody-based treatment. So normally it doesn't require any extra medication. So it doesn't have any nausea, vomiting, or allergic reaction. There is a minor incidence of allergic reaction, but the majority of the time, patient can have this treatment without any immediate risk. But when we trying to tweak the immune system, and this immune system sometimes can missense our normal body organ as a cancer cells. So it can attack our skin. So some patients do get a rash, some patients get a diarrhea, and occasionally it also patients develop the immune infiltration in a different body organ, so that including kidney, liver, or a lung. And also our endocrine glands, so the thyroid, pituitary, pancreas. So those are also some of the side effect of the immune system. But the beauty of this immunotherapy side effect is that when we get side effect, we know that this patient's immune system is activated. And if we have to stop the immunotherapy because of the side effect, they do still derive the same level of benefit as the patients who continue the immunotherapy. So that's the beauty of this immunotherapy side effects, that it still help patient to have a same level of benefit. And the treatment of the side effect is a steroid-based treatment. And over last 10 years, we have learned quite well how to manage the side effect, and it is very manageable side effects.
Right. Okay. That's very clear, and thank you for explaining that, and how the goal of the immunotherapy is to turn on the immune system to attack, so that it can attack the cancer. but occasionally that immune system being turned on can cause autoimmune disease, as you've explained, and various organs are affected. And that's quite a different side effect profile than with chemotherapy, as we explained, with the hair loss, nausea, vomiting, and also the neutropenia and infection risk. This is quite different. So thank you for that, Danica. We interspersed some comments earlier in the evening about, of course, prevention being better than cure, and that's true with all sorts of medical illnesses and cancers. We do have screening in Australia, of course, for cervical cancer, for bowel cancer, for breast cancer, and these have been highly successful screening programs that various governments have put in place. As of 1 July next year, 2025, Megan, the government are going to introduce screening for lung cancer. Can you explain to our audience, please, first of all, why are the government doing this? And secondly, who is eligible for lung cancer screening?
Thanks. Yeah, it's really exciting, the lung cancer screening program. So I guess the government realised that lung cancer is a big problem in Australia. I think you mentioned before it's our 5th most common cancer, but it's our number 1 cancer killer in Australia. So there's a lot of people affected, and sadly there's a lot of people who lose their lives to lung cancer. And what we know, as you mentioned, it's a theme across many cancers, is that early detection saves lives. So at the moment, when we diagnose lung cancer, over half of the time, unfortunately, it's in its advanced stages. And if you catch a cancer at stage 4, overall survival at 5 years is less than 5%. But if you can catch a cancer at stage 1, your survival at 5 years is over 50%. So it's a much more promising situation. So the idea of the National Lung Cancer Screening Program is to pick up lung cancers at an early stage when they're curable, and to prevent deaths from lung cancer. And at the moment, we're hoping each year that we'll prevent over 500 deaths from lung cancer with the screening program. And the eligibility criteria have been defined as anyone between the ages of 50 to 70, and they need to have a history of at least 30 pack years of smoking and be a current smoker, or have a 30 pack year history of smoking and have quit in the past 10 years. And if I break that down, a pack year of smoking is if you smoked, so if you smoked a pack of cigarettes a day for 30 years, that's 30 pack years of smoking. And you can also make that up if you've smoked 2 packets a day of cigarettes for 15 years, that's also 30 pack years of smoking. And so once so that's the group of people that will be eligible for the screening. And I guess to go through the process of how it's going to unfold, if someone presents to their GP and their GP identifies that they're eligible for the screening program, they can agree to enter into the screening program, and then they'll get a referral for a low-dose CT scan of their chest. And they'll go off and have the CT scan and then get the results, and then depending on the results, there'll be different pathways after that point. So if the initial CT of the chest comes back completely clear, the person will stay in the screening program and then have another CT scan in 2 years' time. If there's something fishy that's picked up on the CT scan and there's a moderate or low risk potentially that it could be cancer, that person will have an earlier second CT scan. Some patients at 3 months, other patients at 12 months, and they may need to go and see a respiratory specialist. And then there's a third group of people who have their screening CT chest, and there'll be something that looks really suspicious for lung cancer, and those patients will be referred directly to a respiratory specialist who's linked in with the lung cancer multidisciplinary team.
Right. Okay. No, thank you. Just going back to the eligibility criteria, I think you explained to us a pack year of smoking is smoking one packet of cigarettes that was defined back when packets were a bit smaller than they are now in some instances. So it's am I correct in saying it's 20 cigarettes per
Exactly.
day is one pack year? So if you smoke one packet, but it has 40 cigarettes in it, and you smoke one of them per day for a year, that would actually be a 2-pack year history. Is that
Yes,
correct?
that's the maths exactly. Yeah.
Right.
Yeah.
How does it work for people who roll their own tobacco or use non-filtered cigarettes?
Yeah, so there's ways that we can work out the equivalent of the pack years based on roll your own or other types of smoking. And we've got various little algorithms that we can enter the data into to calculate the pack years.
Yeah. Thank you. Now, you mentioned also that to be eligible for the lung cancer screening, you had to be between 50 and 70. Could you, and I know we always field a lot of questions from audience members about why age limits are put on screening. I mean, as I get older myself, 70 doesn't look that far away, and we get a lot of statements from people who watch these events saying, why does the government cut off screening at a particular age? So why is it only those between 50 and 70 years of age who are eligible for this free screening program?
Yeah, it's a tricky one. I think it just comes down to health economics, really. So they're looking to identify the highest risk group with the highest likelihood of detecting the cancers and I guess getting the greatest yield in terms of finding cancers and curing cancers. So they've got to draw a line in the sand somewhere, and they get very clever people to crunch the numbers. And at the end of the day, the 50 to 70 age group was the sort of the biggest bang for your buck. So that's what they've chosen. But there's certainly lots of other groups of people that are still high risk for lung cancer. So it's not like it disappears when you turn 71 if you've been a heavy smoker. And there's also groups like we were talking about before, like non-smokers who have a high risk for genetically mutated lung cancer who are not included in these programs, or people who've got environmental exposures to carcinogens and things. But I guess at the end of the day, the government's only got a set budget. So they've really just got to pick the group that's at the most risk and at the most benefit from the program.
Right. No, well explained. Thank you. Going over now in the last part of our session to answer your questions, please. And if you do have any questions through the Facebook Live platform, put the question in and we will do our best to get to them. Also, there are many questions generally put in at these events, and if we don't get to your particular question, we will endeavour to answer the question on the transcript that will be available together with the recording of tonight's session on the Icon Cancer Centre Facebook page. So taking a question from our page now, Danique, can I just ask you to explain what support services are required to treat someone with lung cancer? Megan mentioned the multidisciplinary team, and we all know that for caring for patients with cancer, it's not just medical care. People do need multidisciplinary care. So through Icon Cancer Centres and at other cancer treating facilities, what sort of support services do people require, and are there available for patients with lung cancer, Danique?
Yeah, it's very overwhelming when someone diagnosed with the lung cancer and when doctor put the terminal diagnosis. So it's overwhelming for patient, and also there is a quite a hard part for the carer role, like to support the patient and also to support themselves. So in MDT setting, so we have a different specialist together to help with the patient. So we have a We assess the patient, like what burden they are carrying in terms of the symptoms. So we get radiation oncology to help with the pain management, to give a radiation. We get a pain management specialist. Sometimes we refer them to the palliative care to manage the pain. We also have a support service from the Lung Cancer Foundation. So we have a dedicated nurse. In most of the Australia, we have a dedicated nurse to support the lung cancer group. So in Adelaide, we have a lung cancer nurse who liaise with our Icon Cancer Center coordinator. And then they offer the different material to help the patient and navigate through the different services. We also have a dedicated psychologist and dietitian, physiotherapy. It's very hard to believe that the patients require exercise, but that's something what we believe in, that even the patients who have a advanced lung cancer, they do benefit from the dietary intervention, exercise intervention. So it's the whole area of allied health. We work as a team, and that's something what we try to give a patients in a bite size with each appointment and assess them and give them a services.
Sure. You mentioned there exercise and the involvement of a dietitian. If a patient is having immunotherapy or chemotherapy, what sort of exercise is most beneficial for patients, Danique, and what sort of diet should patients follow whilst receiving immunotherapy or chemotherapy?
So now, just to put the first question, like exercise. So now, what the current recommendation is at least patients should have a 45 minutes of exercise per week, and if they can do it 3 days in a week, 45 minutes exercise, like you can, and those exercise could be a different exercise, so which include like a cardio, like a walking, then the resistant exercise, where you can just do a simple band without going to the gym. And the third thing, which is very important, which we often forget, is a balance exercise. Because most important thing when I look at my patient who is elderly patient, to prevent next fall. Like we can look after the cancer, but at the same time, we need to make sure that they don't get a fall, they don't have a memory loss. All those small little things help patients to live better life. And answer to the second question in terms of the diet, like what sort of diet patients should take, it's also depend on what's their weight profile like. Many of the patients have a more than 10% weight loss. Now, those patients are I consider as a red flag and a high risk population, even though they can try themselves to manage the diet, but I think they would benefit from the extra nourishing supplement, and that sometimes can happen through the dietitian, or they can have a high energy drink through the chemist as well. And
yes.
So that's something is very important to understand that metabolic profile.
Yes, no, thank you, Danique. That's great. Staying with managing side effects, over to you, Megan. Would you be able to outline to the audience what are the common side effects patients may experience when treated with radiotherapy for early stage lung cancer?
So with radiotherapy, it's a very local treatment. So it's not like chemotherapy or other drug treatments that sort of go throughout your whole system. The side effects are very specific to where we put the radiotherapy. So I do say to my patients that you may feel tired when you have a course of radiotherapy, but everything else just relates to the location that we're treating. So when the radiotherapy beams are going into your chest, you can get some redness or dryness, like a mild sunburn on the skin. And then when the beams go in, if it's towards the center of the chest, they often have to pass through or next to your esophagus, so tube from your mouth to your stomach, and your poor esophagus can get quite inflamed. So there's a side effect called esophagitis, which we have to manage in some patients who have radiotherapy, where it feels a bit like heartburn, and there can be some discomfort and difficulty with swallowing and eating. And sometimes people need to have a soft, gentle diet and take some painkillers to get through that. But it settles down eventually. And then in the period after radiotherapy, up to 6 months after completion of radiotherapy, I do warn my patients just to look out for a reaction called radiation pneumonitis. Radiation pneumonitis is like an inflammatory reaction to your lungs from the radiotherapy. It doesn't happen to everyone, but it can happen. And if it does happen, patients can get short of breath and they can get a cough and just feel a bit off. And what we usually do then is investigate with a scan, and we see a sort of fluffy white reaction in the lungs. It's the lungs getting inflamed due to the radiotherapy. And that requires treatment with a course of steroids or anti-inflammatory tablet medication to settle that down. And long term after radiotherapy, you can get a bit of scarring in your lungs in the area where we put the radiotherapy through. But usually with early lung cancers, it's a very small area, so it doesn't particularly affect your overall lung function. With stereotactic radiotherapy, if we're treating a tumour that's really peripheral and next to the rib cage, you can on occasion get what we call chest wall pain, which is some discomfort relating to the muscles in between the ribs, and you can even get a rib fracture. It's rare, but it's possible, and rib fractures, as we know, are painful, but they do eventually heal themselves.
Right. No, thank you for that. You mentioned fibrosis. Danique, I'm just going to go over to you now and ask you a question that's come in from the audience that seems sort of a rather curly question, and that is, what is the approach to managing lung cancer that is diagnosed in a patient who already has pulmonary fibrosis?
I think that's one of the most difficult cancer to treat because the options are very limited. And I'm just talking from my first-hand experience, because pulmonary fibrosis is also like a cancer-like illness where there is no cure and it's progressively get worse. So in that setting, what are the treatment which we can offer safely? So surgery, radiation. If we can't offer those two, then probably we have an approach quite similar to any other advanced cancer. I do give a immunotherapy in a patient where they do not have any other options, because sometimes these patients are also have a frailty because of the fibrosis, and they don't really have any other option, safer option. So I do warn them, and then we give a immunotherapy, because remember, the treatment for the fibrosis and immunotherapy toxicity is still going to be the steroid. So at the end of the day, like, it's a risk versus reward kind of scenario.
Right. No, thank you. It's a very helpful answer, and of course, one of many potentially very tricky situations. We're coming towards the end of our session. Again, if you have any last minute questions, please put them up through the Facebook Live platform. If we don't have time to get to the question tonight, we will attempt to answer the question via a transcript on the Facebook page of Icon Cancer Centre. One final question to each of you. Looking in 2025 and beyond, Danique, what do you see happening with lung cancer, and what would you want to give to our audience as your final message for lung cancer in 2025 and beyond?
I think it's very exciting time for a lung cancer patient in terms of having a more option. I think you should not settle for less. Make sure that you ask your doctor to have a discussion in multidisciplinary care. Also ask for any active clinical trial, like we in our Icon Cancer Center, as well as in my public setting, we have a lot of lung cancer trial. And sometimes going into the trial is a way to access some of these novel drugs. And in that way, we can really prolong the whole journey, and many of the patients will get cured. So I think that's very important for our patients to know that there are options, and we should try to push the limits.
Right. Thank you, Danique. And once again, thank you very much for attending tonight's session and presenting so well. Megan, what would your final message and plea to our audience be regarding lung cancer into the new year?
I think the lung cancer screening program is probably one of the most exciting things that I'm looking forward to. I really think we can change the way lung cancer presents, and we can shift it to being picked up early when it's curable. And I look forward to treating more patients with early lung cancer with stereotactic radiotherapy, and seeing better survivorship and just overall better outcomes for lung cancer patients. So I hope everyone can, I guess, be aware of the eligibility criteria, talk to your GP, and get anyone you know who's a smoker to get on board.
Yes. Excellent. No, I would 100%, back up what you've said there, Megan, and say to everyone watching this program, please avail yourself of lung cancer screening when the program kicks off on 1 July 2025. I'd also add to that, if you are still smoking, it is never too late to stop smoking. You will still be eligible for screening because the program covers eligible persons who have ceased smoking within the last 10 years. So on top of making sure you undergo screening for lung cancer, please stop smoking. It is beneficial at any time during your life to stop smoking. Just as we sign off, I'm just going to, I guess, put forward my plea, my wish for 2025 regarding lung cancer, but also other cancers. And in turn, it also answers a question from one of our audience members about why there is such a delay in new therapies for lung cancer being available on the PBS. And unfortunately, we do know that in certain areas in oncology, Australia leads the world. In other areas in oncology, we have a great delay in medications and chemotherapy and immunotherapeutic treatments being discovered and trialled overseas and then coming to Australia many, many years later than they were first used in either Europe or the United States. It's become a real problem, and I think in the media over the next few weeks you will see some mention made by a coalition of cancer groups, charities, leading oncologists and haematologists about some of the ways in which hopefully there will be various drug funds put in place to help bridge this gap and have treatments be available to Australian patients earlier on. So that's certainly my wish for 2025 and beyond, that we can have access to anti-cancer treatments earlier in Australia. It's been fantastic hosting tonight's event. Thank you so much to Megan and Danique for your wonderful presentations and very clear answers. It's been a lovely chat. Thank you to all our staff at Icon Cancer Centre who've put on this Facebook Live series for 2024. Tonight's event will be recorded and it will be on our Icon Cancer Centre Facebook page, together with our now quite large library of Facebook Live events covering all the common subtypes of cancer that we treat and other providers treat throughout the country. As I mentioned at the start of the program, we'll be back again next year. Our first event for 2025 will be on Tuesday, 4 February, which is World Anti-Cancer Day. And so that will also mark our first Facebook Live event for 2025. So thank you to everyone for tuning in, and I wish you a Merry Christmas and very prosperous New Year.